We're now going to move on to the panel section of our discussion, and I'm going to introduce Zach Marieshan. He is an NP from the West Kootenays, and he's also the president of the Association of Registered Nurses of BC, and he will be the moderator for the panel. And for the panel group, you have in front of you a little button. When you wish to speak, you would push that button, your microphone will turn red, and that means you're live. Okay, Zach.
Thank you, Jacqueline. So before we get started, I just do want to briefly thank Mary Lou for giving us the gentle nudge that was the impetus for this. I mean, as an association, we have competing interests with our limited resources, but if we can't pivot and be responsive and expedient to emerging crises like this, then what good are we? So I'm appreciative of that. And honestly, this event here that we're holding in conjunction with the Coalition of Nursing Associations, I think is, I'm most proud of this event more than anything we've ever done. And I want to briefly acknowledge the tremendous work. When did this idea get hatched? 10 days ago? That for staff to put together an event like this and for us to accumulate such a cadre of accomplished speakers and experts in this field, and for all of you to take time out of your busy days to prioritize this important issue. A round of applause for all of you. So, the purpose of this panel, we have 6 speakers, and the point will be to focus on the impact of this opioid crisis and what solutions might exist. And so we'll go one at a time. I will introduce each, and you will have 3 to 5 minutes. And if we're getting close to 5, you're going to get the moose sign, because we want to save time for as many questions as we can. So we'll begin to my immediate left, Cheyenne Johnson. She's a registered nurse and a clinical and research leader at the BC Centre on Substance Use at the Centre for Excellence in HIV/AIDS in Vancouver. She is also the director of the St. Paul's Gold Corps Addiction Nursing Fellowship.
Hi, everyone. Can everyone hear me okay? So thanks so much for having me. I'm really excited to be here and to hear from all of you guys shortly. I'm here today speaking from the BC Centre on Substance Use, which is a new and soon to be announced provincial centre that's going to be housed at the Centre for Excellence in HIV and AIDS in Providence Health at St. Paul's Hospital. And the BC Centre on Substance Use really will have a new provincial mandate to provide leadership for addiction education, research, and care guidance to seamlessly integrate these 3 pillars, or what we call the core functions, into shaping a world-class treatment system that can really reach all patients and families in BC that need it. I think, as many of my colleagues have said publicly before, we don't really need to fix our addiction treatment system. There actually isn't really a functioning system, and this is in part has really contributed to the situation that we're all currently facing as nurses, as frontline providers, as family members, as community members, and I think the speakers that have been here before have spoken to some of the broken systems and the gaps that I'll speak a little bit more to. The crisis, as we know, is multifactorial, it's extremely complex, and every person that's here today brings their own personal and professional and often both perspectives on strategies on how we can address the crisis. I'm really so grateful for everyone that's here today to share their experience and their work. I think this is really key, and one of the functions of the BC Centre on Substance Use is that although it's physically located in Vancouver, we really aim to have a networking function that networks family groups and support groups and advocacy groups, community groups, and groups that represent recovery-oriented systems of care. We're also looking to develop kind of expert networks of clinicians, so physicians, nurses, nurse practitioners, to really further develop addiction communities of practice across the province. So I think today, if I'm just speaking from my BC Center on Substance Use hat, one of the major challenges that I see is the gap between evidence and practice. So what's out there in the scientific literature is really much far ahead of how we are actually practicing today. This includes, but it's not limited to, a real lack of standards and guidelines, evidence-based educations for healthcare providers, lack of treatment pathways to treat addiction in primary care and other specialty environments. Again, that lack of the application of these evidence-based treatment guidelines and pathways into care. Patients and families often have very long waits into treatment, which can be a major barrier, or there's lack of continuity in between different levels of treatment and care. And often folks are facing some coercive treatment environments. The BC Center on Substance Use aims to support healthcare providers through a variety of mechanisms, but for the purposes of this forum, I'm going to just focus on a few key areas that aim to strengthen nurses in training and practice to feel better prepared to care for patients and their families that are struggling with addiction. So again, there's those three core functions: research and evaluation, education and training, and clinical care guidance. I'll speak a little bit to the area of education and training, and some things that we are planning on doing over the next number of years and work that's already underway. One of the first is supporting standards and evidence-based curriculum and the development in education and training programs for nurses, for RPNs, for LPNs, and for nurse practitioners. I think across the board, addiction sort of falls within the curriculum area of mental health, but often gets probably less focus and less, again, of that evidence-based practice that we need as nurses to communicate with patients and their families. We're working to support entry-level, advanced practice, and nurse practitioner core competencies. We're looking to create and expand postgraduate training opportunities. So this includes the St. Paul's Gold Corp Addiction Nursing Fellowship, which is the only nursing fellowship in North America that I'm aware of. And we're looking to expand this across the province so we can really enhance and build nursing expertise, not just only in the Lower Mainland, but everywhere in British Columbia. Working towards advocating for equal training opportunities for nurse practitioners to support their new role and enhance prescribing to treat an opioid addiction with maintaining buprenorphine, naloxone, or Suboxone scripts and methadone to come. As well as we have a forthcoming online addiction medicine certification program that'll be coming out in the early part of 2017, which will be a CME accredited online self-paced module for all healthcare providers that can access this type of evidence-based training on their own time and hopefully supported again by their organizations to enhance their knowledge of addiction. The other piece that I'm going to focus on, and one of the biggest initiatives, is the clinical care guidance. So recognizing that the BC Center on Substance Use, although a lot of us are healthcare providers or come from that background, we don't actually provide healthcare. Thanks. So we're poised to release new provincial guidelines for the treatment of opioid addiction. So these are going to come out in early 2017. And there's really two key messages that I want to share with everyone from those guidelines. The first is that we're recommending Suboxone be the first-line treatment for opioid addiction compared to methadone. It has a 6 times safety improved profile compared to methadone. And I think it's not really widely known out there, but methadone was actually implicated in 25% of prescription opioid overdoses in 2015 in BC. The second piece is that withdrawal management strategies alone, so that's just putting people into detox for their opioid addiction and doing a short methadone or Suboxone taper or nothing at all, and then really closing the door behind them and not connecting them into care is actually more harmful than leaving people in their active addiction. So we really need to create those continuities of care between withdrawal management strategies and outpatient and residential and other treatment strategies. The other key piece is that these guidelines really aim to integrate harm reduction at every level. So harm reduction not just being a standalone treatment intervention or a standalone intervention, but really looks to support patients across the care continuum. So again, really really briefly, I spoke about that we need to really build a functioning addiction treatment system. And provincially, I really think that nurses play a very important role in this. I just came back from Boston a few weeks ago, where they're leading this area in terms of nursing-led models of care. For example, they have an outpatient buprenorphine clinic, which is case managed by 5 nurses. Everyone is connected into primary care and sees their physician every 4 months, but 5 nurses alone can treat 700 patients with opioid addiction on buprenorphine, and this really just enhances the ability of our system to increase access to evidence-based treatments that patients need. That's all I have. Thank you very much.
Thank you very much, Diane. I will next introduce Jordan Westfall. He's the president of the Canadian Association of People Who Use Drugs. Jordan has a master's degree in public policy from SFU. His experience as an OxyContin, fentanyl, and heroin user inform much of his career path. Jordan.
Thank you. So people who use drugs are exhausted out there, but they're resilient and resourceful. But they're very sick and tired of inaction. They're sick and tired of political cynicism that prioritizes someone else or something else over their lives. It's sadly ironic, but it seems everyone wants to speak on behalf of an overdose victim after their death. New laws are passed in their names, their faces adorn the front pages of newspapers, and politicians promise to never again take their lives for granted. In death, overdose victims are publicly granted the humanity that could have saved their lives in the first place were it offered earlier. While they're breathing, nobody wants to listen. How could they? They won't even be in the same room with us. They don't consult us, include us, or consider if policy they make could mean more of us dead. If we want to reduce the stigma that keeps so many from reaching their full potential, if we're serious about valuing the people living through this trauma right now, we'd start appreciating them while they're living, not just remembering them after death. We humanize people when they're already gone, when it matters the least. Any meeting about this epidemic that I walk into, I'll see more pictures of dead drug users than living drug users invited into the room. There's 1, 2, maybe 3 of us, but endless pictures of dead faces on the wall. There is endless potential, inner strength, and heroism in people who use drugs. There are some of us out there who have saved more lives than medics in combat zones. The people who will open a supervised injection site on 24 hours notice to save the lives of people they care about. The people who fought this since the beginning. But still, the last people consulted on matters that influence whether they live or die. If you want to support people who use drugs, allow them to make a difference. There's a damaging misconception that people who use drugs cannot make rational decisions for themselves. How to combat this is to put people in positions to make a difference, to make decisions, to have some financial stability, to work. At the end of a long, horrific year, victories that we fought so hard for seem insignificant. Even though the Respect for Communities Act that regulates supervised consumption sites is going to be repealed, we look back and see mass casualties across the country. We have to think ahead to ensure this never happens again. Many institutions have failed us. It's unsurprising because the people most aware, the most knowledgeable, the people who know our system most intimately are not sitting in these institutions. We see leadership at a national level, places like the Canadian Centre on Substance Abuse, a public health body with law enforcement sitting on their board, or the Center for Addiction and Mental Health recommending doctors stop or recommending health care plans stop insuring prescription opioids while people turn to the streets and bootleg fentanyl as prescription opioid access is restricted. These independent bodies that seem unwilling to face what is happening, but they should know. We open sites where drug possession is decriminalized because it saves lives. We're decriminalizing drug possession at the scene of a drug overdose once again because it saves lives. We prescribe heroin, methadone, hydromorphone also because it saves lives. All of this points to one obvious direction that our institutions need to recognize. Drug decriminalization could end this epidemic. Thank you.
Thank you, Jordan. Next, we have Mark Tyndall. He's the Executive Director of the BC Centre for Disease Control and the Deputy Provincial Health Officer. He is an infectious diseases physician and researcher who has over 15 years of experience working in the downtown east side. He has conducted a number of community-based research projects as well as provided clinical care at several downtown east side clinics. Mark.
Great, thank you. Good morning, everybody. It's unfair to me to have to follow Jordan, so we could just skip what I want to say and move on to the next person. So I really, want to echo what Jordan said as far as what we need to do now. It's been, the message is this is an extremely complicated problem. Addiction's extremely complicated, but stopping overdose deaths is not that complicated, and we know how to do it right now. And there is a real inertia here. I'm here with my Deputy Provincial Health Officer hat, so I can talk a little bit about the high-level discussions that go on at the Ministry of Health level to try to make policy decisions, which is, to me, sitting at that table, extremely frustrating because there's a lot of great ideas, but things move very, very slowly. Having said that, last week, Terry Lake decided to start breaking some dishes, and things change quite quickly. And for those of us who have been advocating for supervised injection sites for decades, this in 24 hours it kind of changed, and basically saying that we can't wait for your legislation from Ottawa, that saving lives is much more important than sending you documents for a federal exemption. So that experiment, it was unleashed in Vancouver and the rest of BC just last week. I've talking to Megan right now, there's still some hiccups along the way how this will actually roll out, but I think it was a real shot across the bow saying, look, this is ridiculous that the pop-up site that a lot of the attention was focused on in Vancouver is a life-saving intervention, and we cannot be stopped by somebody at the Health Canada having to sign off on a large application project. So these are not, should not be illegal. And the irony of this is our only response right now to helping people prevent death is to tell them that the drugs are very dangerous. If you choose to use them, make sure that you have somebody with you that can give you naloxone. Be sure that you can call 911 and don't inject alone, which is exactly the definition of a supervised situation for people to inject in. And then we tell people that's our life-saving message, but by the way, it's illegal. So I think it was very important that we really made that statement, and this group can be very instrumental in making sure that goes through, because there will be some hurdles. It's happened so quickly that the usual suspects of opposition haven't even had a chance to take any of this in. So it's just it happened very quickly, and we can expect that there'll be some pushback as people get organized and really understand that these are supervised injection sites, and we can call them overdose prevention units, which I think was a very smart way to kind of change the language a little bit, but at the end of the day, we're really advocating that people deserve supervision. I was able to speak to the people on the island about supervised injection site a month ago and had a talk around myths and around this whole epidemic, and I just wanted to highlight a couple of them that I talked about. One is this is not a new problem. So although the overdoses numbers have skyrocketed in the last year or so, this is overdoses of people using illicit drugs has been with us for a long time, and we should not be satisfied that we were dealing with 300 to 500 deaths per year before this really hit the newsstand. So this is not a new problem, and what was pushing this in all along is the same issues we're dealing with right now, which Jordan talked about, stigma, in people really don't care. And so if this was happening to any other population, for sure we'd be doing much more. But it's really a forgotten population that really deserves a lot more attention. And 300 deaths is still quite serious, and we weren't even recognizing that. The other thing, this is really, the media's framed this as a fentanyl epidemic, and we really call this, really the focus is on fentanyl now, and really has allowed the dialogue to go much more into the war on drugs. So we're back to talking about law enforcement, how we stop fentanyl, how we do more prohibition, how we're going through Christmas envelopes coming from China to try and find small bits of drugs. I mean, the prohibition is what's driving the whole thing in the first place. And so these are all counterproductive, and people will rely for the foreseeable future on an illicit drug market, and all they're asking for is drugs that won't kill them. And the more we clamp down on the prohibition, the more chance we'll have the drugs kill people. Interestingly, I think the data from Insight's very interesting, that nobody's died of an overdose. So Peter Mansbridge's on television looking at elephant tranquilizers and carfentanil, but the fact is that these, if the drug, it's not the drug, it's how it's mixed and how people take it, and it's not a fatal overdose. So the idea that the public and moral panic that all of a sudden we're confronted with these drugs that are thousands of times more potent is really a side issue, and it's really having a supply of drugs that people can access that won't kill them, and that's prohibition just feeds more into that, and so we can't be on the side of doing that. And the other myth is that all the people out there who are currently using these drugs just need treatment, and that's not true either. Most people have been offered treatment multiple times. They're on and off treatment. I definitely believe people need better access to treatment, don't get me wrong, but we're not going to solve the problem if everybody gets on Suboxone tomorrow, because they won't. And then the alternative is that the rest of the people who have failed, all they need is prescription heroin in a very expensive supervised manner, and again, that's not going to happen very quickly either. So for the majority of people at most risk right now, they just need drugs that won't kill them, and we have to make sure that that happens, and explore all kinds of ways to getting people prescription drugs, including through their family doctors. And Leslie's, the driving people with some stricter opiate prescribing back onto the streets and searching for illicit drugs is exactly what's feeding into this overdose epidemic. So that is not the approach either. And it's the people that are getting on these drugs and unnecessarily definitely need to be stopped. But people who are currently on high-dose opiates, the last thing they need is to be restricted from continuing to get their prescriptions, because that's what's causing a lot of the problems. Okay. Thank you. Okay.
And I think you'll find you're in a room that's in favor of breaking dishes when necessary. So next up is Megan Thumath, and she's a registered nurse of public health and public health leader in HIV and drug policy. She's a former coordinator at Insight and a leader of BC's provincial HIV strategy. She has over 10 years of clinical and health policy experience.
Thanks, that's fun, because I never gave a bio, so I was like, what are they going to say? So I think nursing happens at the intersection of sort of politics and the personal, so hopefully you'll indulge me. I'm going to share a bit about my personal story, and also trust that I'm in a room of nurses that aren't going to stigmatize me, but here I go. So I think one of the first times I've shared this story and being recorded. So the first time I used crystal meth, I was 14 years old. I'd just broken up with my first boyfriend, and feeling vulnerable, went to a friend's house who had an older brother that had introduced us to speed. While we were getting ready for our party and putting on makeup and listening to music, I was offered my first line. And I think it's probably true to say that I spent most of my teens chasing that first hit of dopamine, because you never get such an intense high as your first time. I'd already tried many other drugs, but speed was different. My drug use, though, didn't occur in isolation, sort of from the sort of social determinants of health that were impacting my family. It was compounded by the economic depression that forced my working class family to uproot from a thriving community where we had our connections to a more dangerous environment. It was impacted by the intergenerational trauma experienced by my Irish parents, by the sexual violence and endemic drug use experienced by residential school survivors in the poverty-stricken community where I grew up of Chilliwack. Many of my classmates did not survive. At 15, I started working at our local needle exchange, and by the time I was 19, I was pregnant with my first child. I like to think that he saved my life. During my prenatal care, I met community health nurses who taught me about nutrition. In the labor and delivery room, I met compassionate nurses at BC Women's who helped coach me through my labor and taught me to breastfeed. No one called Child Protection Services, and no one was unkind. Sadly, this was not the case. I was later to learn in my career as a nurse at Sheway for many of our clients, especially for women of color. Eventually, I found my way to UBC, and I met many other nursing giants who are in this room today. And through the coaching of my public health nurse, really, and my outreach nurse, I was encouraged to consider nursing. I became a street nurse, which was one of my first jobs at the BC Centre for Disease Control with many of the awesome nurses in this room. And later worked at Insight and eventually found my way at policy tables at the UN AIDS and World Bank and many other interesting and wild places. But everywhere I've done this in the service of advancing social justice and equity, particularly for people who use drugs. And always with this perspective that at any point that overdose or that AIDS death could have been me. At different points in my career, I've had to handle complaints from fellow drug users about how they felt ignored or mistreated by nurses. Just last week, I had a young patient overdose when I was working at the tent, and he refused to go to hospital because he felt he would be treated poorly. This has always remained truly heartbreaking to me because I know it's not in our nature as nurses to be unkind, to stigmatize, or to marginalize. Why does this happen? Fear, stigma, compassion fatigue, many of the things that many of you have talked about today. When nurses are unkind, and I will say that this is happening, it's almost always because we don't have the tools we need to do our jobs. We don't have the training about harm reduction, about trauma-informed practice. We can't offer our patients a safe place to use or a clean supply of safe and regulated drugs that Mark and Jordan talked about. We can't offer our homeless patients a home. We can't find a detox or treatment referral for our clients who need it. This can and must change. Today, I have a thriving 17-year-old son, and I pray that he will never find himself where I was at 17. But that if he does, there will be a kind and a compassionate nurse with naloxone and a hug that we're famous for, fighting for his right for safe spaces and for clean access to medicine. This must include access to supervised injection, to prescription heroin or hydromorphone that's easily accessible in primary care, and to evidence-based treatment. It's what we would want for all of our children, and it's what all Canadians deserve, to be safe, to be loved, and treated with kindness by nurses and by their community. The nursing community and nursing associations must work together to end the war on drugs and to protect our loved ones. Thank you.
Thank you, Megan. Second to last, we have Miles Randall, who is an advanced life support paramedic with over 20 years' experience. He's employed by the BC Ambulance Service, volunteer for North Shore Search and Rescue and Squamish Search and Rescue. He has resuscitated countless narcotic overdoses over the years and has seen the tragic effects of addiction. He is keen to help find an approach to help solve this crisis.
Thank you. Can everyone hear me in the back? Thank you for involving me in this forum. I spend my typical day outside responding to people in crisis. So today I'm humbled to be invited as the outsider in the room, inside to help address this terrible crisis. Firstly, I want to be clear that I'm speaking today of my own experiences. I'm not speaking on behalf of the BC Ambulance Service or my other employers. I'm just speaking about my own experience and those of my paramedic colleagues. This crisis has taken its toll, not only on the people tragically lost to the opioid crisis, but also to the responders and healthcare workers that are tasked with responding to this crisis. I responded to overdoses in the back alleys and apartments that surround us here, multi-million-dollar homes in West Vancouver, and even the snowy mountains of British Columbia. This crisis truly crosses all boundaries. I'm also a new father, and I want to do my best to ensure my son doesn't fall victim to the horrors that I've seen. As a community of people that not only provide care, but actually truly care, we need to approach this crisis as a team, involving bystander training, emergency responders, healthcare workers, outreach workers, and policymakers. That is the value of forums such as this. Thank you.
Thank you, Miles. And last we have Tim Gauthier. Tim has worked as a nurse since 2008 in a full-time capacity with experience split between frontline nursing and clinical coordination. He's also currently enrolled in the Masters of Nursing Nurse Practitioner program through UVic. His passions are harm reduction, addiction, and mental health. Tim.
Hi, everybody. This room is intimidating, not because of the people, but because of the shape and the grandeur of it all. And it's not what I'm used to, for sure. So my name is Tim. I've been nursing at Insight since 2008, and I kind of happened upon it by accident. I started there as an employed student nurse when I was in nursing school at UBC, and I was so excited to come to Insight. And then when I got to Insight, I was so surprised and overwhelmed by the kindness. I get overwhelmed all the time when I talk about this, but okay. I think the thing about Insight that I've always appreciated and adored and held close is the way that we do care about drug users before they're dead. Like we see them and we know them and we feel them and we share things with them and with each other. And in times like this, when Kat was talking about not accepting a new normal, we haven't accepted it, but we've like contextualized the way we're relating to each other because we don't have time. It's person and person and person and person who is in a lot of trouble. So we're constantly splitting our attention. We've got one person with an airway in, we're trying to get air into them, their chest is so rigid and tight and they're blue and we're worried about them, but then we can hear that something else is happening, but we can't split ourselves in a way that's meaningful enough to get to them right now, because our priority is this person right here, right now. Which happened. Like the other day, we were trying to bag somebody and we got a call to up front, and it was 2 nurses because it took 2 because this person was in so much distress and we just couldn't get air in. And then we got a call to up front, and the other nurse was like, "Okay, I gotta go." I'm like, "You can't leave right now. Like my hands are too slippery. I can't get a seal. Like you have to stay. Like we have to get air into this person." So we just screamed for help, and luckily help was there. We had a 3rd nurse who was available. In a different role. So they responded quickly and they ran up front. But in that time, like we had to choose. We had to make a really hard, gross decision. Like that right now we can't get to that person. And we knew they were in trouble. We've had other times like where people have been really sick. Like we know we have to take them in the treatment room. We know we have to see them in there, but we just can't leave the floor. Like we just know that we've got too many people to monitor. We can't leave them. I can talk to you out here. And it's just not how we've been. So as we're describing situations to each other, we often just say, "Ugh, like new normal." And we're not saying it like to accept it, we're saying it as like, this is our context. So I think what we haven't experienced is a lack of kindness. We still want to engage in each other in the same way that we always have, in the same way that I think we always will. But there's just a worry. There's just a worry that we're not going to be able to, even though we're feeling that kindness, we're feeling that connection, we don't know if we're able to communicate it in that same way. So we talk about all these things that are happening outside, like these new initiatives that are fantastic, like the mobile unit, the pop-up sites, all those things we are in incredible support of. But also like there's this epicenter or the eye of the storm, it feels like, where we have these skyrocketing overdoses, these skyrocketing emergencies. We just haven't had any like tangible, reliable, consistent help. Like it's reactionary. Like it's today I go in, if I have 4 overdoses all at once, I'm gonna call for a backup nurse. But I gotta wait for that to happen. Like we communicate to staffing has to do a call out, and we're waiting. Like we're waiting for help to come instead of just having help here. So I've probably gone over 5 minutes because I had a little breakdown. So I'm gonna turn off my microphone. To questions.
Thank you very much, Tim. So we will move to questions that you can pose to this brain trust, and we have a limited amount of time. We may restructure the remainder. I'll look to our MC at some point, but I will begin to take questions. Surely someone has a question.
Thank you, Zach. Michael Sandler, ARNBC, Rural Policy Table.
Can't hear.
Sorry, can you hear me now?
Yep.
Hi, my name is Michael Sandler. I'm here with the Rural Policy Table, supported by ARNBC. My question is to the table regarding scope of practice. Have we addressed some of the issues related to nurses administering naloxone as a Schedule I drug outside of a client-specific order?
I can address part of this, and then maybe everyone feel free to jump in. But my understanding is also naloxone has been completely descheduled, so it's no longer a Schedule I drug. And I haven't been, with everything going on, I haven't stayed completely up to date on what's happening with the standards of practice for naloxone, as well as for the take-home naloxone program. But my understanding is that naloxone is much more widely available and will be much more widely available, both in pharmacies and over the counter. So now that it's descheduled, those issues should no longer be in part. I don't know if anyone wants to add anything, or anyone from the college.
Oh, we pushed the button.
Oh, there we go. Hi, my name is Gail Ansel, and I'm the practice consultant from the College of Registered Psychiatric Nurses. And I just wanted to let you know that it is still a Schedule I medication. Naloxone is still a Schedule I medication in hospital. However, there is no limits or conditions from our college on dispensing. Just some follow the DST and have the competency to manage naloxone in the administration, prescribing, and dispensing of it. In the community, it is a unscheduled medication, and from our college, there are no limits or conditions on any facet of administering, prescribing, or dispensing naloxone in the community. Thank you.
Excellent, thank you. That answer your question, Mike?
Yes, thank you. We should probably make nurses aware that they can now administer this medication in the community to friends and family who aren't their clients, because that was a big barrier previous.
Yes, we changed our dispensing practice standards so that we can dispense to, before our dispensing standards said that we had to dispense to a client, and that the education around that had to be to that client specifically. And we've actually changed our practice standard to say that we can dispense naloxone, it's the only drug, but we can dispense naloxone to anyone.
Great. Well, we'll definitely push through our social media and newsletters on this. Other questions?
Hi, my name's Monica. I'm one of the nurse educators at the BC Centre for Disease Control. Just further to what this gentleman was asking, in terms of the limits and conditions around the dispensing of naloxone, the CRNBC just put out a media release, I believe, to the members in Nursing Matters that the limits and conditions will actually be lifted early January for the dispensing of naloxone. And I'm sorry, I forgot your name, but the lady was correct in indicating that naloxone will remain a Schedule I drug for in-hospital acute care settings, but for the community, it won't be. Those limits and conditions will come into effect in early January.
Thank you for that clarification. Do you want to go ahead?
Thank you. Dorothy Cumming, a nursing instructor at BCIT. I just want to emphasize how my partners are in this crisis situation in their roles, in their practice roles, and yet Insight and CTCT has continued to accept my students during a group practicum, only asking us not to come when the staffing situation is in a crisis. So the education of student nurses is, we're right in the thick of it right now, but the curriculums that we have, that I'm working with, you're quite correct that the addiction piece is very small. And I'm one clinical instructor from our agency in the downtown east side for 96 students, so 8 of them have the potential to get the experience. So when I think about solutions, we need nursing education to really have a big, healthy focus on drug use, addictions, and so I welcome the announcement of getting that kind of support. I think you all know, many of us in this room are community health nurses background, and we're often low man on the totem pole in an acute care focused curriculum. Thanks.
Thank you. Any questions for this panel here? Judy.
Thank you to the panel for very powerful presentations. I have a couple of questions. What do you think we need? It's clear that that nurses and first responders are incredibly stressed, overwhelmed. What more support do we need on the front lines to prevent more deaths from overdose? And my second question, it really picks up on the statement that was made that we don't really have a functioning treatment system. So it's not so much about fixing the system, it's about building a system. And I certainly hear that as a member of the legislature in my constituency office. Very high needs community, that people come in the door desperately looking for help and treatment, and if they've got money, they can, Cadillac extended health plans, they have access to treatment programs, and if they don't, they don't. So I guess my question is both what do we need to do to support staffing and increase staffing on the front lines to prevent deaths, and what do we need to do to ensure there's treatment for people who are at the point of needing treatment? Because I've also heard police officers say, or ambulance paramedics, we save a life, but there's nowhere for us to take people if they want treatment.
Would like to take that. Mark?
Yeah, I mean, again, this is not really a new problem. It's been brought to the forefront because of all these deaths. So I think that there's a lot of, everybody's just so different. So it's it's just obviously not one size fits all kind of approach to things. And I do really empathize with families trying to get their young people into treatment facilities. I think that we really need to break down the barriers between abstinence-only treatment facilities and ones that are more of a harm reduction thing, because it really does limit, and there's a whole industry out there of abstinence-based treatment programs that don't fit for a lot of people, and so we need to break down some of those barriers and bring some of the resources into a more harm reduction approach to things. We define addiction as a chronic relapsing illness, and we treat it as though 2 weeks in an institution and you're cured, and that's just not the experience for 95% of people. So it's an ongoing investment that we need to put into this, and we have not even started thinking about that, what it really takes. So I think that's one thing. And then the idea that people, one of the points I was trying to make is that not everybody's going to be wanting treatment. So that there's people who are going to be reliant on illicit drugs for the foreseeable future, and that we just don't want to let them die. So I've had a lot of people in my career who just never really get beyond on and off methadone treatment, on and off different treatments, and they're surviving, but that's about the best they'll be able to do, I think, and we have to make it possible for them to continue to survive in that element, and not everybody's going to be amenable to treatment.
Thank you, Mark.
And maybe just to add really quickly, totally in full agreement of everything that Mark said, and I think just to add to it is to really enhance the ability of primary care to support treatment for folks and families that are struggling with addiction, because it is a chronic relapsing condition. That's where we really treat most chronic diseases in our communities, and so training healthcare providers and training folks to screen, recognize, and treat addiction, but also understand that like other chronic conditions, there's treatment intensities and different levels of care that can be offered, some that are suitable for primary care, and others, when folks want it, to move up kind of treatment intensity to methadone, to slow-release oral morphine, which is a treatment option that should be available to folks, and to injectable treatment options like diacetylmorphine or prescription heroin and injectable treatment options. So recognizing that that's a continuum, but also that people can move up that continuum, but that they can also move back down as they get better and their lives improve.
Thank you, Cheyenne. Sue, did I see your hand up? Oh,
Yeah.
okay. Oh, sorry. Tim wanted to briefly comment on that.
Yeah, and then I think, like, for our part, for Insight, I think what I was trying to get at is that we also just need, like, urgent, like, we need extra help now. Like, there is a plan for us to get the LPN at some point, sometime, but right now it hasn't been posted. Like, we don't know when that's coming, but we need help, like, right now. So, like, for other crises, like when we're, gearing up for the flu blitz, like, we put a call out amongst the health authorities, like, to pull other nurses from other programs to support us if they're casual or they can. But we haven't done that with something like this, and we could. Like, Insight orientation currently consists of about 3 orientation shifts and then some education courses, like, around that. So it's, like, a really quick, like, we could get people up and running really quick to help. So I think for our part, we need help. Soon.
Thank you, Tim. Sue, and then that woman over there.
I'd like to focus just for a minute on the changes around prescribing OxyContin and the unintended consequences. So if I understand it correctly, we have had a period where OxyContin was prescribed in some cases inappropriately, and we have Leslie where she mentioned that in part of her discussion. So we have a period of perhaps inappropriate prescribing, and now we want to change that. But so there seems to me 2 streams of people who were prescribed and how they are managed and assisted in their needs and perhaps their addiction, and moving to a more rigorous and thoughtful prescribing regime. So I was wondering if there was any strategies around how we move from one situation to another, or are we imposing the new prescribing regimes on all cases now, and what is the consequence for that, and is that what we should be doing?
Excellent question, Sue. Any comments on how we solve the iatrogenic problem other than cutting everyone off with no options? Mark?
Sure. I think that's an incredibly important topic, because there's a collision course happening at the same time, and one's feeding into the other. So it's hard to find a family doctor who doesn't have a sign on their wall saying no narcotic prescriptions on it, because they're scared of the new regulations and they just don't want to get involved in it. And so that's a really that just constantly feeds more people into this illicit market, which is very, very bad. So I think there are people, Evan Wood and his group, and with these guidelines and things, I think that's part of the focus that they're doing, because I don't think there's clear guidelines yet about what physicians are supposed to do, other than tell their patients that in the next 3 months we have to wean you off this because I can't prescribe it anymore. And that's clearly a bad message to give to people, and to make the new starts a much different concern and a totally different issue than what to do with people who are currently prescribing. What I found, I see Pam and Andrew here from Ottawa, but I mean the different, when I worked in Ottawa, there's a whole different external supply of these drugs. So we were really a heroin-rich city, as opposed to a place like Ottawa, which there wasn't very much heroin, and the currency of drug use there was OxyContins. And the delisting of OxyContins really threw that whole community into turmoil, and they were the first turning to fentanyl patches and things, and it's just a matter of time before powder fentanyl gets there. So it's really a problem with the currency of prescription drugs that really drives a lot of this the whole currency of drug use, and to take that away at the same time as we're dealing with a crisis of overdoses is hugely problematic, and we really need to come up with very specific guidelines about how we deal with this.
Thank you, Mark. In order of hands, I saw your hand and your hand. Did you still have a question?
Yeah, I'm a nurse who I work at Insight and On-Site and on the street with primary outreach services. And I'm hearing a lot from a lot of people about the push for cleaner prescription opiate replacements. And while Suboxone is great, and it's great for some people, it's not a one drug, fit solution. For a lot of people, Suboxone, I've seen people go on it 9, 10, 12 times, and in the meantime, they're dying. You asked what we could do, and what we can do is push these opiate replacements that we've already said in the 2016 opiate replacement guidelines we can do, long-acting morphine, diacetyl morphine, these other solutions we can place people on. We need to push it. We need to actually see it. We need to see it now, because you can see on the street the effect that has on somebody's life, and it's huge. But we talk about it a lot, and I hear a lot of talk about it, but I can't get anybody on it. It's in the guidelines of replacement, and I can't get anybody on it. So that's what we can do is, yes, this is an emergency, but as Tim said, this could be our new norm. This could be it. And so while we need things now, and we do, we need preventative measures as well. We need clean drugs that are prescriptions. We need housing. We need mental health support. We need things so this can't possibly be our new norm. So, thank you.
Megan?
Yeah, I just want to thank you for that comment, and I won't say the doctor's name because I don't want to get them in trouble, but at the Portland Hotel Society, we have had success with having a few clients on hydromorphone, which is, something that's available. It's ward stock in many of our hospitals, and it's available in the primary care system. So it's not prescription heroin, which is quite complicated to import, which we have across town, but it is something that the drug using community wants, and they can inject it. And what we need from our partners in government is resources and money, because currently it needs to be supervised, and people need to inject it between 3 and 5 times a day, generally by whether it's a regulated pharmacist or registered nurse, and that's what we don't have. And I mean, Mark's been great in the media saying, if this is our Ebola, we really should have had a massive public health investment. Like, we found resources and funding during the Ebola crisis, swine flu, other things, and we're just not seeing that from government, either federally. I think provincially we're starting to see a trickle, but the fact that you guys are working at Insight and you've had nurses, like the same staffing, the 2 nurses that we had when I was coordinator and we worked there, and we had a few overdoses a month, and that you haven't gotten an additional staffing. And I mean, additional LPNs, that's nice, but we should have additional emergency nurses who are more experienced than us. We should have additional NPs and physicians and RTs. We should be there should be a massive investment in there, and it should be 24 hours, which it still isn't. It's still only 24 hours, I think, on check week or something. I mean, we're not scaling the interventions we know that work. And I think that's what I would love, like your advocacy, and if there's any federal partners in the room, advocacy to declare a federal public health emergency, because it needs to come with resources. I'm sorry, it costs money to save lives. It costs money to scale up hydromorphone.
Well said. Thank you, Megan. Our MC wishes to exercise her right as timekeeper and test the room here.
Excuse me, I have a comment. I just want to say something quickly. Sure. Sorry, I was back, but you didn't see me. I'm Sherilyn. I'm a nurse educator in the downtown east side. And I actually want to thank you, Tim, for expressing your emotion, because there's many of us former Insight nurses here and current, and I think we all remember what it's like being terrified all the time of having an overdose happen. And I just want to say that, so as nurses, we're super good at taking care of other people and super shitty of doing that for ourselves. And I just want to say I work really closely with primary outreach services, and just on that team alone, we've had nurses that in one day assisted 3 overdoses, the same nurse. The overdoses are particularly gruesome and hairy and more difficult than the ones that I used to see at Insight. So I just want to say, for the people, the nurses here that have been assisting in overdoses, I'm super concerned about your emotional and mental health. And as I sit here, I don't actually, because we are so bad at taking care of ourselves, I have no ideas of how we can support each other. So I'm interested, like I want to open up to the room, to Mary Lou or other people. Kat, you said at Insight you got together. I want to find out how you guys did that. Tomorrow we're debriefing some really bad overdoses that have happened to the team, and that's all that I can think of. I know we have really supportive management and that they would totally support us in getting together, so if you have ideas, maybe we can connect somehow and share those ideas. Thank you.
Thank you. I'm quite aware of our time and that we're past our break, and I want to offer two options to the group. The one option would be to have a 10-minute break now so people can go use the washroom, have coffee or a snack, and come back and carry on with some of this discussion. Also, we also have the open forum. Or we can forgo the break and people can come and go as they please to grab coffee or whatever they need and carry on the dialogue. So I'm asking you what your preference is. How many want to take a quick break? How many want to just sit in here and go in and out? Okay, so the group would like to stay here, which means if you want to take a quick break, you can do so silently, and we'll answer a few more questions before we shift to our open forum.
Great. So please, no judgment if you want to go use the washroom or get some coffee. So a couple more questions directed to the panel, and then we will switch to the open forum, which will be a more sort of generative discussion. I saw you in the blue first, and then you in the green.
Is that on? Oh, yeah. Hi, I'm Serena. I'm a nurse at the Immunodeficiency Clinic in Crosstown Clinic. And I just wanted to comment on your question about the new prescribing guidelines. In practice, we've seen even some very experienced physicians taking them as the be-all, end-all and really quickly tapering people off of opiates who have been on opiates for a long time. So I think as nurses, it's really, really important that we advocate, because there's such a power imbalance between our clients and our physicians, that we advocate for these clients that that's really dangerous and they're going to become dependent on street drugs and subsequently overdose and die. So I just wanted to point out, yeah, again, the new guidelines are great, but they don't work for everyone, and nurses need to help out in making sure that everyone's safe.
Thank you. Not sure comments. I'll let you go ahead.
So my name is James, and I'm a nurse who, let's see, how do I align myself here? Because half of my bosses are sitting in the room. So maybe I'm an instructor at VCC today instead of a ex-street nurse from the Center for Disease Control. I'm old enough to have been around way back in the day when this first wave of overdoses was happening, through the crazy 90s when HIV was layered on top of that. And worked in the downtown east side with Mark, and not Megan quite then, you were still, I think, in diapers. But the thing that struck me is that we were yelling and screaming for something in the four-pillar approach that was not solely focused on enforcement. And I remember touring around the province with Philip Owen and Nettie Wild with Fix, the story of an addicted city, and this whole idea of harm reduction seemed brand new. And as I sat here listening to the nurses from Insight talking, I felt that same frustration that we felt back in the day from the activism that we undertook to get the safe injection site opened, or the supervised injection site open, and it seems like we haven't gone anywhere with respect to that. Except for to take a little bit of the focus off enforcement and put a lot more on harm reduction, to the point that we're really, really challenging the people who are doing harm reduction work. I'm getting to a question. I just like talking. I think if the question that we're asking here today is what can we do, what we're looking for is a change. And I think some of the need for change and the changes that are needed have been eloquently stated by people like Leslie, and thank you. I wish you strength. I'm a parent myself. That's hard stuff. But it's like we forgot the prevention and treatment pillars. We got all excited about harm reduction and really put a lot behind it. And Mark's comments notwithstanding about some of the challenges around prevention and treatment, that they're not the be-all and end-all, it's still something that I don't think we really fully understood even way back then when we identified treatment, harm reduction, prevention, and enforcement. So bringing it to today, I think we're sitting in the choir here singing to each other. The two challenges that really, really strike me as I sit in this room is, where are the people with lived experience? I was really struck by the comment that Jordan made around that. And I just direct all of us who are thinking about doing this kind of thing to look at peerology and look at Nothing About Us Without Us, because those give us a roadmap for doing that. Simply inviting them into the room isn't enough. It's a complicated and difficult thing to do properly. The other thing I just want to point out, and I'm going to challenge my boss, Mark, here on this one, is I don't think we see change without leadership standing up and yelling from the rooftops that change needs to happen. And as I listen to the media and as I hear what's coming across the airwaves, I hear Donald McPherson talking about the stuff that I think we're all agreeing needs to happen. I hear Mark Hayden talking about it. And I guess other people are talking about it, but I don't hear the change leaders in our institutions, ARNBC, CRNBC, public health institutions, standing up and boldly saying, this is where we have to go to make this happen. It's all fine and well to sit in a room and say it to each other. But if we don't say it in the places where it matters, in the places of power and in the media, we're just talking to ourselves. And I think that's the change we need to see happen within the pushing the direction of this into something that's going to get our focus off burning out our harm reduction workers and continuing to focus on enforcement.
Thank you, James. So your challenge is accepted. I appreciate that. Way in the way back.
Okay. My name is Jen, and I'm the patient care coordinator at the Burnaby Center for Mental Health and Addiction. And our treatment program opened after the Olympics. And when we first started out, we were harm reduction. That presented a number of challenges. So since that time, we've switched to being abstinent-based. But having said that, I want to point out that we do support clients who have frequent relapses, as well as we use a number of harm reduction approaches to care. And I think as nurses, we're all faced on a regular basis with a number of ethical implications. And I just wanted to bring something up because we do treat clients who are certified. We would like them to be motivated for treatment. And in terms of, we use the word ambivalence, but that is a bit of a slippery slope. In my career, I've worked as a psych nurse for 20 years. I've had lots of conversations with clients. I've had lots of conversations with family members, and people just so frustrated because when someone is in the heavy stages of addiction, they may not have, an understanding or insight into the seriousness of it. And, sometimes, and I've spoken with clients who are certified, and when they initially went into treatment, they were not motivated, they did not want to go, and they said, thank God I went into treatment. That saved my life. At the time, I wasn't able to see it. Now I do. I'm so, but unfortunately, sometimes some really serious things need to happen before that happens. I speak with family members, and I have said to them, it's frustrating, but someone does need to be motivated or expressing some desire for treatment before and they're saying to me, well, you know what, they're addicted, and I'm watching my family member die, and I don't know what to do with it, to do about it. I myself struggle back and forth. Obviously, we want these clients to have rights. You can't be pushing people into treatment. But I don't know. I personally, for myself, I feel like adolescents, if someone is seriously addicted as an adolescent, they should be forced into treatment because, if I was a mother myself, that's what I would want. And I've talking to parents of adolescents who feel completely helpless. Their adolescent child is prostituting themselves, heavily addicted. There's absolutely nothing they can do about it. And I guess I just wanted to sort of put it out there, to the people on the panel, anyone who wants to answer it, or anyone else, just, their thoughts about, treating people who are not necessarily motivated for treatment, and their thoughts on that.
I think, thank you for your work, and I think it's really important that there's evidence-based treatment like what's available at the Burnaby Center. I've tried to get lots of clients in there. I wish I could get more in. I just think that there needs to be a continuum, and that if you feel like you need to leave, like I left my community not for treatment. I left to do Canada World Youth and went to South America. They didn't know that I was detoxing when I was there, but they didn't really need to know. Like I had a great experience, and I lived abroad for a year and learned Spanish and left, the drug using community that was drawing me back in, and then I came back stronger and went to university and whatever. But there is a lot of evidence that sometimes communities of people do almost as well. Like when you look at people who've been through treatment who just kind of grew out of their addiction and got to go somewhere else, they do almost as well. And I think we need to unpack that and understand it more. In my experience, I've seen people downtown get really well by volunteering and starting to give back to their community and by being engaged as peers, and that's kind of what I've witnessed as being one of the most powerful experiences. I think absolutely some people want treatment and really need it and should have access, but I also think as the nursing community we have an opportunity to use our voice. We're often named as one of the most trusted professions after firefighters and paramedics. And I think we need to also use our voice to say, hey, like some clients might need injectable hydromorphone, some might need Suboxone, some might need treatment. They should be able to access it, but we should be open to sort of the variety, and there should be as many forms of treatment available as there are beds, rather than just demanding sort of simple, not that you're demanding that, but simple beds.
Quick point from Mark.
Yeah, I mean, it seems quite intuitive, but I think it doesn't work. So there's examples, you can probably find anecdotes, but there's been mass experiments in other countries like Cambodia and Thailand that round up young people and force them into these mass treatment camps, and the recidivism is probably 99%. So, I mean, and that's been, pretty much everybody's experience forcing people into treatment. So I don't think that term works. If you're 15 years old and living on the street, I think it is a tragic thing to deal with that kind of situation, and we need to pump in as many social services as we can and as many supports and many options. So I think that's, your point is not that we should just forget about it and wait till somebody's ready for treatment as we described. So there should be multiple opportunities for them, many more than there are now. But I think the term probably forced treatment probably is not part of the discussion.
Thank you, Mark. I'm going to wrap up the portion of the speakers panel because we do have yet more time to discuss and have a generative discussion in an open forum section. So I will thank the panel for their contributions and hand it over to the MC.